Hi, welcome to You and Your Health. I'm your host, Dr. David Bertone. Today's topic is about recent advances in joint replacement surgery. As the population continues to get older and we have more and more geriatrics in our country, we're starting to see more surgeries to improve their joint mechanics and their overall function. Our guest today is Dr. Mark Gessell. Dr. Gessell is a board-certified orthopedic surgeon. He practices currently in Tinton Falls, Freehold, and Toms River. He has a specialty in joint replacement surgery, and he's here today to talk about the procedures. Dr. Gessell, welcome to the show.
Thank you.
Tell us a little bit about your background and how you got involved in orthopedic surgery.
Well, I did my undergrad training at Stanford University in California. Decided that I liked sports medicine, so realized that was orthopedic surgery. I'd always wanted to be a doctor, so went to medical school in Chicago at Loyola University. From there, I'd gotten a scholarship to attend medical school through the U.S. Navy. So completed medical school, did residency training in orthopedic surgery at Robert Wood Johnson, and then did 4 years in active duty in the Navy.
Very good.
Then after those 4 years, decided to concentrate in hip and knee replacements, as that was one of my favorite surgeries to perform. And then so did that at a hospital for special surgery.
Great, and that's obviously a big place around here where people go for those procedures. But the important thing is now people have access locally in their community. I think that's important. Where they used to have to go to New York for those kind of procedures, now the advances are coming here.
It's a big volume center with excellent surgeons. The problem is getting there.
Mm-hmm.
So you can have your surgery there, but if you need to call your surgeon, if you have an ache or pain, if you have some question about it, it's hard to get back up to the Upper East Side to see your surgeon up in New York. So.
Yeah.
Hip and knee replacements it's a very standard surgery. It's one that most surgeons are comfortable with. So doing it locally makes a lot of sense.
And there's some recent advances that we're going to talk about, but I want to mention some of the statistics that are pretty staggering. By the year 2030, the number of knee replacements is going to increase from 450,000 now per year to 3.48 million. So that's a pretty big number.
Mm-hmm.
And the number of total hip replacements is going to go from 200,000 to 500,000. So there is a significant increase in the number of these procedures. So that means more surgeons, more skill, hopefully less time in the hospital. How are we preparing for some of these things? How are we getting ready?
Well, there's clearly advances in all aspects of hip and knee replacement. The surgical technique is improving, month by month. The materials are improving yearly across the board with each implant company. The hospitalizations are getting shorter, trying to get more efficient, trying to get patients back at home where they're more comfortable.
Great.
So trying to streamline the whole process.
Now, before we get into the actual surgery and talk about it, let's go through some of the general mechanics and the most common procedure is the hip and knee. Obviously, you can do joint replacements in other joints, but this is the most common. So
the osteoarthritis is the most common form of arthritis.
Mm-hmm.
That's wear and tear arthritis. That's usually going to be the weight-bearing joints, so your knees, your hips. Mm-hmm. Rheumatoid arthritis is less common, and medications have really taken over the treatment of rheumatoid arthritis. So replacements for the shoulders, the elbows, the wrists, the ankles, those are less common and usually because of rheumatoid arthritis.
Okay, great. So let's review the knee joint just so people have a general understanding of what we're talking about here. Can you just review some of the general areas and what's involved in terms of what degenerates over time?
So here's your standard knee, so we can flip the kneecap over. A lot of people will develop arthritis underneath their kneecap. That's very painful, going up and down stairs, squatting, sitting for a long time. Here's the meniscus. The medial and lateral meniscus are here. That's a C-shaped kind of cartilage, provides some cushion. And then there's cartilage lining the bones on both sides of the femur and the tibia here. So with osteoarthritis, we lose the cartilage, the cushioning here on the bones. Then you also start getting degenerative tears of the meniscus. And then gradually you wear out these structures, and then you get bone-on-bone arthritis, and that's what causes a lot of pain.
Okay. Now let's take it to the hip joint. If we can just review the general anatomy of the hip joint. I know that's a ball and socket joint. It's a little different than the knee.
So this is one that's already been replaced. But basically you have the hip joint, the proximal femur here, and then the acetabulum, the socket part in your pelvis. So you get some bone spurs, you get some degeneration, loss of cartilage all along the acetabulum and along the head of the femur, right, this ball right there. A lot of people will get pain on the outside part of the hip. Over on this side, that's more related to a bursa. People who have real hip arthritis, they'll get groin pain, inability to kind of tie your shoes and rotate your hip, and that'll really manifest as as a groin pain. And so again, that's just the hip and socket joint there that we're going to replace.
I think it's important to clarify that in the hip, there's no big piece of cartilage like this, right? It's more articular cartilage. Maybe you can just explain the difference there.
So instead of a meniscus, there's a labrum around the hip joint. It functions a little bit differently than the knee. It acts more like a suction cap just to keep the hip joint in the socket. So you can tear that, but that's again a more common injury in younger athletes and younger people. But it's more just the joint, the cartilage lining the joint that starts to degenerate.
And that's like I like to describe when I tell my patients the shiny part of a chicken leg.
Exactly.
Right?
Once you lose that, bone on bone, and that's very painful.
Okay. So somebody comes to your office, what are some of the common complaints that they would have regarding their knees or their hips where you're starting to think maybe they need a joint replacement surgery? What is a typical workup like?
It's joint pain, stiffness, and swelling. It usually takes a couple years to get all the symptoms till they really start interfering with your daily life. But with knee pain, if they start walking for any significant time, they'll get some knee swelling. They'll have trouble going up and down stairs. They'll have trouble putting on their shoes, and they'll get groin pain with the hip arthritis. And then it starts interfering with their daily life. They stop playing golf, they stop jogging, they stop taking a walk on the boardwalk, and that's when you need someone to take a look at it.
So the first step is usually a conservative approach, I would assume, right? You do some testing to confirm your findings, and then what would happen next?
And getting an X-ray is the most important thing to get right away. A MRI or a CT scan are much more advanced, more expensive tests that are really not needed for most osteoarthritic patients. And X-ray is a quick, easy, cheap test, and we can follow the X-rays over several years to see if there's any change. With the X-ray, you can also see how much cartilage is lost, so how much narrowing there is in the joint and how advanced the arthritis is. And then once the arthritis is starting to advance, it's really how the symptoms interfere with that patient's life. That determines whether we try some conservative measures or we go to surgery.
Now, what would be the typical conservative first step? Would it be medication? Would it be physical therapy, bracing? What is the...
All the above.
Okay.
We try, activity modification. If it bothers you only when you squat, maybe you can go on with your life without having to squat or do lunges in the gym. We try some medications, some anti-inflammatory medicines, and Tylenol help. After that, we can try some injections into the knee, either a corticosteroid injection or a viscosupplementation, like a thick gel-like fluid that helps lubricate the joint. And then physical therapy, strengthening the quads and the hamstrings helps take some of that force off the knee joint. That helps with the pain.
Okay.
And then weight loss too.
Yeah, that was the other important thing I was going to talk about is what are the risk factors here? What do you typically see? I know we're starting to see some younger people get the joint replaced, and we can talk about that, but what is the typical makeup of the patient that comes in with this kind of degeneration?
Well, a lot of it's genetic, so we can blame our parents if we get it. But as our society gets a little heavier, that puts a lot of stress on the hip and knee joints. For every pound of increase in body weight, your knees will experience about 5 times more force in the knee joint, especially going up and down stairs. So that's a big deal. If you lose 10 pounds, you can take 50 pounds of force off your knee. That's really going to make a big difference.
Okay. So now somebody comes in and they've gone through all the conservative approach. Let's talk about the hip per se. They come in and it's time to do surgery. Talk us through the process and what are some of the recent advances in terms of some of the materials that's involved here.
So for hip surgery, It's usually, the surgery is about an hour and a half in length. You're typically in the hospital for about 3 days. You can have an incision up in the front of your hip, the anterior approach. You can have one on the side, the lateral approach, or from the back, the posterior approach. That's all surgeon dependent. You know, most studies show that the patients do about the same no matter what approach you use. So it's really whatever your surgeon's most comfortable with. The implants have, really the materials have gone through the most advances. You know, all the instrumentation's gotten a little smaller. We're able to do the surgeries through smaller incisions. But here's a short stem, a standard hip replacement. So again, this is, with the ball and the stem, and that goes kind of right up into the socket there, and right into this femur.
Now,
in a different socket.
Now let's talk about the different materials that you see here. This one is really shiny. This one's like a darker surface.
So there's different advances in the materials. So the most standard one is using a metal head like this one. The next one would be using a ceramic or a ceramicized metal, which is this next one.
I'll take that from you.
Which is this guy. So this one, the ceramic is a harder material. It's going to wear less, and so that should theoretically last longer. This company makes one, it combines a metal and a ceramic, and again, that shows that it's going to hopefully last a lot longer than a standard metal one.
And what about this side, on the pelvis side? Is that something that's typically metal? Do you use plastic in there sometimes?
So the most common one is to use a plastic. You put a metal liner in, and then you can put a plastic socket liner, and then you'll get a metal or a ceramic ball onto the plastic liner. That's the most common combination. The hip resurfacing, again, is another brand new, newer surgery. This implant's been in use since 1997, but what this allows us to do is take less bone off the femur. So especially for younger patients, we can really keep most of their own bone in their femoral neck and the head, and we really only cap the head. This allows a much bigger head as opposed to this standard one, and some are even smaller than this. The bigger head allows for less dislocations. It gives you more range of motion, and gives you a more natural feeling hip.
Is there ever a time when you just replace this part and not this part?
Unfortunately, if you do that, the metal is going to wear against whatever cartilage is left in your hip. So there's very few indications. Sometimes for hip fractures, someone who's not very active, doing a shorter procedure, just putting in a stem and putting in the head will allow that patient to get back, quicker. But someone who's active, who's really wants to get back to activities they were doing before for an elective hip replacement, we do both sets.
I want to talk about the 3 approaches that you mentioned, because it's interesting. I'm starting to see more patients with the anterior approach, and I can tell you from a physical therapy standpoint, they seem to do better and have less weakness in the outside, the lateral part of their hip, which tends to be always a problem with the hip replacements post-op. They have kind of this lurching gait. We call it a Trendelenburg gait, but they lurch. Do you see any difference in that with your patients?
The short-term outcome with the patients through an anterior approach is excellent. The patients tend to get out of the hospital, about a day sooner. They do have they can have some less pain early on, but that is relatively short-lived. It's a little, the approach is a little bit newer. You can't extend it as well as going through the back. So certainly doing a revision or doing a bigger surgery, it's easier to go from the back. But there have been some excellent results going through the front. But, the goal is not to walk well within the first week or two. It's to get pain-free and to get well-aligned implants 6 months, a year, 10 years down the road.
So you might consider that for a younger person, somebody more active that needs that increased function right away, or?
Well, it's really surgeon dependent.
Okay.
Most surgeons are much more comfortable going from the front. Most are more comfortable going the standard posterior approach. That's the most common one. When you go through the side, you really can weaken the muscles that help extend your leg, and that weakness can persist. But it's really, I think, at this point, it's really surgeon dependent. You want your surgeon to be comfortable exposing all the anatomy and putting the implants in the right position. That's the most important thing.
Great. Okay, when we come back, we're going to talk more about the hip joint, and we'll talk about the knee replacement surgery.
I am Joan Rivers with an important announcement. Getting old is horrible, okay? Horrible.
You're not old. I mean, you're older, but you're not old.
You want to see old?
Oh, God.
Yes, grow up, for goodness sakes. The last man to hit on me was an undertaker. I know where
I don't want to talk about
Well,
this,
you're going to
Mom.
have to talk about it. It's the future. It's coming right at us. And I'm not worried about dying. It's getting there. I mean, heaven is going to be fabulous. It's going to be a giant shopping mall, and there's going to be 20% off on everything, except for me, 44.
You know, you're doing jokes, and I'm just not ready.
Well, you have to be ready. You have to listen to me. Look, there are things to discuss. They're going to be my needs. They're going to be my wants.
You know, Mom, I don't want to hear this. I just don't want to hear this. La, la, la,
Don't give me la, 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 la.
I don't. I can't. I can't
Talk
do this.
to your family about aging, even
No.
if they're not ready to listen. Come on, listen to me. Listen to me.
For the first time?
Yes, for the first time.
No matter who you are, it's not easy talking about aging. For help, go to voa.org/talk. A message from Volunteers of America.
Hi, welcome back to You and Your Health. I'm your host, Dr. David Bertone. Today's show is about recent advances in joint replacement surgery. Our guest is Dr. Mark Gessell, a board-certified orthopedic surgeon. We were talking about hip replacement surgery, and Dr. Gessell, if you can just continue on about what happens after the surgery. What is a typical course of treatment like for people?
So again, about 3 days in the hospital. You'll get physical therapy starting the day after surgery. You can put weight on the implants as soon as the surgery is done. So depending on how well people do in physical therapy, like to get them home as soon as possible. So if they do well with the physical therapy in the hospital, they can go straight home. If not, they can go to rehab for a couple days or a week or so.
All right, let's talk about the precautions. And we all heard about them over the years. You can't cross your legs, can't bend too far. What's the status with that? Is that pretty standard still? Or?
So if you do an anterior approach, there's really no precautions afterwards. You don't violate the capsule in the back, so there's less chance that that hip is going to dislocate. If you do the posterior approach, some surgeons are getting away from doing any hip precautions at all. The heads are getting bigger, so the stability is getting better as the implants and the materials have improved. But the biggest thing is, since if you're going through the back, again, you're removing that capsule from the back, so there is a chance that it's going to dislocate out the back. So we for the first 4 to 6 weeks, let that soft tissue heal back up. So again, no crossing your legs, no sitting in a low chair. Those are really two most important ones.
Okay, great. And then what can people expect long term? How long can the prosthesis last, and what can they get back to? What if they bowled, can they do that? Can they play golf?
They can basically get back to anything that they were doing before. There are very few long-term restrictions for hip replacement patients. The prostheses now, the implants are getting better and better. The materials are lasting longer. So it really should be, we shoot for a minimum of 10 years, but they're really 15, 20 years they should last now.
And when it comes time to a revision, when you have to do a revision of a hip, just briefly, what is involved with that process?
So doing a revision, again, usually is for loosening, for that wear that builds up. You get debris, it kind of loosens up around the stem or the cup of the prosthesis. So the surgery is a little bit longer because you have to get the old implants out. We can lose some of the bone around the hip and the socket. So sometimes we have to put in a bigger cup into the pelvis. And then usually we go from a stem similar to this, and then we have to put a revision stem is basically something like that. So it's much longer than the previous stem. So we just have to, it depends on how much bone is left.
And there'll be several factors like osteoporosis and things like that will be an issue.
Exactly. But once the implant is in, again, a little bit longer procedure, but you should be able to get back walking right away and expect to get back to the function you had before.
And it's important for people to know that's kind of one of your skills, and a lot of surgeons tend to shy away from that, like they don't want to do surgery in somebody else's surgery. But obviously this is a revision that needs to be done, and it has special skills involved with it.
Yes, so getting a workup is important to figure out why you're getting it revised. Either it's loose on the x-rays and it's very clear, either you have an underlying low-grade infection, can be a reason. If you broke around the implants, that's also more common since the metal's harder than the bone around it. You know, just a fall can cause a fracture around the implant. So just sort of an unexplained pain in the joint. Again, you just want to make sure you get the right tests and studies before you rush into doing revising the whole thing.
Okay, great. Let's move to the knee now. Obviously, the knee is a little bit more complicated of a joint, and I know there's some advances that you would like to show in terms of which prosthesis you would choose and things like that. So if you can talk us through that, that would be great.
Yeah, so standard knee replacement, again, we're replacing the femur, the tibia, and then usually putting a little metal plastic button on behind the kneecap there. Each company has improved the instrumentation, so the instrumentations are smaller. That allows us to do the same surgery through a smaller incision, again, helping speed up recovery. The most common material used now is this cobalt chrome. Again, very shiny, very hard. So there's some companies have, this company, Smith & Nephew, has this oxidized zirconium called oxinium. This is a harder, smoother surface, and so this can really decrease the wear in the joint. And also the plastic has gone through some improvements. So it's a harder, stronger plastic, again, less susceptible to wear, which is going to increase the longevity of it.
Or you can talk about the lining up and how you decide where to do your incisions and things like that.
Well, most of the incisions kind of right up in the front of the knee. Again, we just kind of move the kneecap over, and then we just, we're trying to resurface the lining of the bone. So really we're trying to take out as little bone as possible from the top and the bottom and the back here of the knee, just to try to replace only what we need with the metal and the plastic components. Now, there's certain, brand new designs from several manufacturers involved sort of a custom instrumentation. So what this involves is getting an MRI or a CAT scan of your knee. You send it to the company, and they'll make a custom custom instrumentation for you. This allows, once you get in surgery, it lines up right on your bone, and then it allows a much simpler procedure. There's less instruments involved. Instead of putting a big rod in through the femur, you put this one thing right on, and you can get your cut a lot more precisely. So this allows less inventory in the hospital. It speeds up the surgery because you know exactly what size implant you're going to put on. And again, it gets the much more precise cuts. So that's going to be the wave of the future, is the custom implants.
That's very impressive. I mean, to be able to customize it based on the size and individuality of each person really probably makes your job easier.
And as the knee wears, it's going to wear in slightly different patterns. You're going to get these osteophytes or bone spurs forming in different locations. So these custom instruments go right over those, and it only will sit one way, and then you get, again, a very precise, very exact cut.
Great. Now, some people hear the term minimally invasive. What does that mean when you're doing joint replacement?
Really over the last 10 years, there's been an effort to try to decrease the size of the incision, decrease the trauma to the knee and to the hip, and to try to speed up recovery. So, we really tried to emphasize exposure, 20 years ago. But we're doing the same thing, again, with smaller instruments. So there's no reason to make an incision from your hip to your knee. We can really make one, just above the kneecap or right at your kneecap and below, and really see what we need to see. The instrumentation is smaller, so it fits in that smaller incision, and then we're able to do that same procedure through a smaller incision. There's less trauma to the tissue, so you're going to recover a little bit quicker. You're going to get, the pain's going to be less.
Does the size of the person make a difference in how you determine, from a surgery standpoint, your incision, if it's a large male or a very small frame female?
It does. A 100-pound female with who's very thin, you're really going to be able to do it easily through a small incision with very mobile tissues. A 250-pound muscular linebacker male, that person's going to have bigger bones, bigger muscles, and that's just going to require a slightly bigger incision.
All right, now let's talk about post-op. What typically happens to these patients after this surgery?
So knee replacement surgeries, those patients are staying in the hospital about 3 to 4 days. Again, you can put weight on it right after surgery. You're starting in physical therapy in the hospital the day after surgery. And the biggest thing is moving the knee. You really want to make sure you get the range of motion back. Whenever you make that incision up through the front of the knee, there's a lot of scar tissue that can build up. So you don't want that to limit your final outcome. So you really get the patients in either a continuous passive motion machine, a CPM, so that just gradually bends the knee back and forth on its own. And then the therapists help, obviously just manually helping to get the patient to bend their knee.
And what are the goals? What are the expectations? How much motion can they expect to gain after a surgery like this?
So a normal knee will bend about 140 degrees. So that's somewhere down to here. Once we start getting some arthritis, most patients will start bend it to about 100, 110 degrees. So with the newer implants, you were basically shooting for between 120 and 130 degrees of range of motion. So with that amount of motion, you'll be able to get back, do stairs, sit comfortably, walk, do basically everything you need to do.
I tell my patients the first goal is we want to get about 105. 105 is a thing that makes it easy to go around on a bicycle.
Yep.
Makes it easy to sit in a chair, and you can go step over step on the stairs. So that's kind of our first big goal in the rehab. What happens if you don't start getting that? What are some of the things that you have to consider if the motion's kind of going slow?
The motion is the most important thing. That's why we start early. By 6 weeks is sort of the perfect time to try to achieve that 90 or 100 degrees of range of motion. If you're significantly short of that by 6 weeks, the best thing, and that there are a lot of factors for that. Either you build up scar tissue early, either there's, your pain control hasn't been good. So either there's some, you don't do as much therapy because the knee hurts a little bit, because you're not responding well to the medicines. So you want to make sure the pain control is adequate. But by 6 weeks, you really want to get that 90 or 100 degrees. And so if you don't, by that point, doing a gentle manipulation where we just take you into the hospital, we just sedate you, we just gently bend the knee. That helps break up some of that scar tissue that's formed, and then generally those patients get back and increase their therapy.
Yeah, now when I see those patients, that's a big help, because a lot of times they're just really stiff and they're just not going anywhere. But that 6 week time frame is the one
After
you look
6 weeks, that scar tissue really starts to sink in, and then it becomes much more difficult, if not really impossible, to do it through just bending it.
Mm-hmm.
You just want to anesthetize them just so they don't feel their legs, basically, and you just bend their knee. That's all you're doing. After 6 weeks, that generally doesn't work. You generally need too much force to sort of break up that scar tissue. So in that case, it's better just to kind of take them back to the operating room, open it up, kind of clean out the scar tissue surgically. So that's why you try to get it by that 6 weeks.
And what can they expect? Are there any precautions for the knee replacement patient? Can they go back to running and sports and things that they used to do if they did it before?
The only thing I try to limit is running. Okay. The more you pound on the implant, the better or the higher chance that it may loosen a little bit. But any sort of low impact exercise is fine with a knee replacement. You can jog, you can walk, you can bike, you can play doubles tennis, you can ski, but just a lot of running is the only thing I would really limit.
And again, the life expectancy before revision might be necessary?
Well, again, we used to say about 10 or 15 years. The newer implants are lasting significantly longer. This one, again, by this company, Smith & Nephew, with the oxidized metal, which is more like a ceramic, and this newer plastic, this one's been tested to last 30 years.
Wow.
So that's sort of 45 million cycles they tested at bending this implant 45 million times. And this implant has shown about 80% less wear than a standard knee replacement after 3 years. So again, this one, the wear rates are continually to improve. And again, that's just the better materials that we're using.
Great. Well, thank you very much for joining us. We appreciate it today.
You're welcome.
And thanks again for joining us. I'm your host, Dr. David Bertone, and you've been watching You and Your Health.